really hard. So good afternoon, everyone. Welcome to the CTC seminar. And today, and for those of you who don't know me, I'm Linda Cook. I'm the Associate Director for Population Sciences at the Cancer Center. And unfortunately, neither Jamie nor Stacy could attend today. So they're here in spirit, though, and they're very sad that they are missing this talk. So it is my great pleasure to introduce Dr. Ben Brewer. Ben came originally from Connecticut, but then he came to the University of Denver, got his master's and then his PsyD in clinical psychology at the University of Denver, went off to the Rocky Mountain Cancer Center for his fellowship, and then came back to CU Anschutz, and he's been here ever since. He's an associate professor and the director of the Clinical Psychology and Counseling Division of the Hematology Department. They're their own department, right?
Yeah. Division, yes.
They're a division of hematology. Thank you. And he's done all sorts of interesting things. He has done some work in sleep factors in oncology, so something that's very important, as well as I love your caregiver work for the allogenic transplant patients. And then there was one other thing that you were kind of big on, if I remember correctly. Oh, just generally the behavioral health interventions in oncology has quite a history of that, and has done a lot of things with training of providers, training of, trainees, just all sorts of things like that. So today he is going to talk about addressing gaps in psychosocial oncology care. So I think we're going to hear about some of these topics that I've just already mentioned. And without further ado, I turn it over to you, Ben.
Thank you for that introduction. I am a clinician. I have about an 80-20 split. And so this is a talk from kind of a clinical angle, but I'm talking about research. So apologies if I'm not in my right camp. I've never presented this idea to people in an organized fashion like this before. So I'm very open to feedback and other ideas and questions. And please feel free to interrupt me when I'm talking. So I want to talk to you about addressing what I see as a major gap in psychosocial oncology practice, and a solution to that gap, one of many that could be, using clinician education to bridge the gap that I see. And so I want to highlight this gap that I just mentioned between research and clinical practice in psychosocial oncology, and some of the reasons why I think it might be so large and durable. And then highlight the use of clinical education, as I said, to kind of take a public health D&I approach to sort of bridge that gap. And then I want to do this through the lens of 4 projects that I've been involved in that use novel educational interventions for cancer clinicians, and then discuss some of the common components of how we scale those down to be useful to folks practicing more in a community setting instead of a research setting. So first of all, congratulations, probably most likely to everyone in this room who's been part of many of these development projects that have built in the last 50 years excellent psychosocial interventions for fatigue, insomnia, anxiety, depression, pain, existential concern, and many, many, many more. As you all know, we have these tools. They've been well researched in RCT formats, now more recently in comparative effectiveness trials with PCORI and other funding sources targeting that kind of thing. And many of them have even been refined and tested in more externally valid populations using consecutive patient studies and things like this. And this is fantastic work. And it's really a huge change in the last 50 years that this has happened, and it's been accelerating, I think. It's remarkable. I think we should give ourselves credit as a field for this. Obviously, there's endless work to be done here, and we still need better interventions, and we need like this fundamental research into what works for these problems in oncology. I'm not saying any part of this talk that that's not valuable. At the same time that that's been building up, many of you will recognize Jimmy Holland here, who is the godmother of our field. Jimmy was a remarkable human being, and psychiatrist from West Texas. I got to work with her on the NCCN distress management panel, which I'm still a member of. And she essentially founded the field of psycho-oncology, as you know. And she also established APOS, IPOS, and the distress management panel. So a lot in one career. Her first book was called The Tyranny of Positive Thinking. And I like to remind patients of that when they tell me that everyone keeps telling them to be positive, but they don't feel positive and they feel isolated. She was very much had the patient at the forefront of what she did, and I really respect her for that. Unfortunately, she died in 2017, the day before Christmas. She died suddenly. There was a 2007 IOM report that is at the beginning of many people's R01s and other grant mechanisms, which said that we need cancer care for the whole patient. And it highlighted this gap that I'm talking about today, that there's a major gap in research versus clinical practice, noting specifically that we have strong evidence-based approaches, and this was in 2007, but these are not reaching patients. They're not getting all the way to patients. And so in 2011, we had mandated distress screening for the first time, and that was responsible for building up clinical programs across the country, like in a remarkable, wonderful way. And we still are engaged in that work, and screening takes a lot of work. And then more importantly, when you screen someone, you need to be able to treat the symptoms that arise. And in cancer, that's really, really important. So it sparked this big growth. And now we have additional growth in the survivorship area. So we have survivorship care planning that's being mandated and has been worked on for the past decade, and many other aspects, and now have guidelines in that area. So all to say that on the research development side and the sort of clinicians working with the patient side, we've had a tremendous amount of buildup over the years. But I would argue that despite some very great efforts in this area, many people being concerned about it, that we still have this huge problem. So I'll ask you rhetorically, like, why there's a huge gap between research-derived treatments that work well and the clinicians' actual practice with patients. Now, when I say clinicians, I'm talking about the average clinician in psycho-oncology, not all the fancy people you interact with here that are highly trained and go to these kinds of talks. It's a different population we're talking about. And if I were to define the problem, I would say in very simple terms, we have these amazing interventions that I've mentioned several times. After trial completion, most of these sit, unfortunately, unused in an academic office, never to reach the average clinician working with cancer patients. Many of these are unsustainable, and they actually don't work in a clinic setting because we don't have the resources to do them. And patients don't actually want to do a big structured protocol. They want to do something different. And every clinician knows this intuitively and would never dream of doing that to their patients. And so we have these things built, but they're not really built for outside of research. And so one reason, which you're all unfortunately very familiar with, is this is kind of it's the game, not the player. And so to be a researcher in psycho-oncology, you have to survive. You have to get grants. You have to publish. And we all know this rule. And so everyone's under tremendous pressure to do this. Institutions are under tremendous pressure to do this. And so my sense is they sometimes forget about later step translation, and they tend to focus on just funding. And a lot of funding is developing these interventions, taking things that are known in the field of psychology and applying them to cancer patients, which is great. But these protocols in psycho-oncology tend to be long. Sometimes the sessions are 90 minutes. You know, these are big involved things. They're designed on purpose for high internal validity and fidelity to clearly see signal from noise. I mean, you're not going to get your R01 renewed, you're not going to get published things, you're not going to be able to keep being a researcher if you can't show signal from noise, right? That's just the thing. And so I don't blame anybody for doing this. It's sort of the way the system's set up. But I think that it mostly rewards successful trial outcomes, and it doesn't really reward helping patients. And I think everyone would kind of agree with that. It's like we wanted it to be like the medical drug development model, but we don't have the structures that medical drug development has, which when there's a very successful trial, there's a ton of money pulling that to patients and a ton of patients and doctors saying, we really want that right now. And that's not a perfect system either. It's got all kinds of issues with money and power and things like that. But I think we expect that to work for successful behavioral interventions. And I don't think we need the same system. I think we need a different system. That is beyond the scope of my job, is to restructure the academic network of America. I'm happy to talk about it, but what I want to focus on is a more narrow solution that I think we can actually maybe all do in different ways. So who provides psychosocial oncology care in the US? The vast majority are social workers. Some of those are more extensively trained social workers with an LCSW, some are LPCs, and a lot is informally by RNs who don't have a lot of training, but help their patients nonetheless because they're great at what they do. The average number of patient visits for a therapy intervention is actually 1 or 2. And I put 2 to 3 here because I think if you actually have a therapy patient that comes to you for that, you might have 2 to 3 visits. That's what we kind of have resources for, and that's honestly what happens in most oncology clinics. And so it's important to remember that about 65% of oncology occurs in community cancer centers with much more limited resources than a center like this. So a recent Association of Community Cancer Centers survey of their oncology teams revealed that a lack of well-trained, qualified professionals to refer to is the primary limiting factor for addressing psychosocial problems. So the physicians were like, we really like this, it's great, we know it works, but we don't know who to refer to, and the people we have maybe aren't trained or maybe there aren't enough of them. That's what they said. I think that many of the people in these centers, often social workers, as I said, they're also tasked with having to do resource things that aren't therapy. That's a lot of what they do. And the institution wants that because if you solve those things, people can get treatment, and that's what the university gets paid for, or their institution gets paid for. So many of these folks, though, are excellent therapists. They really want to do a good job, but they're resource limited and they're education limited. So from my view, I've never completed an 8-session in-order intervention in oncology outside of being part of a research clinical trial or a structured psychoeducational group where you just have people sign up for a class, basically. So we don't do this in therapy. And I think if you talk to most cancer clinicians on the ground, they don't do 8-session protocols either. They don't do 6-session protocols. And then cancer clinicians also have trouble accessing the scientific literature. One of my pet peeves when I first got into psycho-oncology was you read about this great trial and they had great effect size and patients loved it and it was efficient and it was great. And you go to look for what they actually did and it says, oh, we had components on social support, on cognitive stuff, on exercise. They don't tell you what they did at all. And obviously that's because of journal space limits, right? But in medicine, we say we use this monoclonal antibody and we made it this way. And we can't do that in psycho-oncology. So you're stuck with, if you even have access to the scientific literature as a clinician locked in a cancer center without an academic component, you're still stuck emailing the researcher. And most researchers are really nice, but they don't always get back to you, right? And then the protocol is not built. So I want to ask the field a little bit why we are funding these massive, highly structured protocols if very few can use them in a primary setting. It's not that I don't think we should fund them at all, but it feels like NCI's priority is on these things, and it's not on things that are built for the clinician. Many clinical programs do have really solid education, so these social workers and psychologists and other people in our field are pretty well trained at sort of 10 years ago basic intervention science, right? CBT, third wave behavioral therapies like ACT, exposure therapy. They have an idea of these things. I wouldn't say that they all use them. They often do supportive therapy, which I don't think we should knock. It works very well. If you've ever read the common factors research, it's like really shocking how well just building a relationship with somebody is effective for almost everything. And I think the average clinician is excellent at that, but I still say we have these problems. So if I get more serious and look, instead of just complaining, look at where this problem lives, I think most of you are familiar, because we're in cancer prevention and control, with this phases of translational research. So just to review, basic science research is like figuring out how to sequence DNA. Obviously, we did that a long time ago, but when we figured out how to sequence it, that was T0. When we figured out how to make tests and make useful things in humans and animals out of it, that was T1. And then T2 is where you're really transitioning to patients. And I would submit that most psycho-oncology researchers in academic centers like this one do T2 research. They are involved in recruiting patients, into a trial of a novel intervention that has been garnered from T0 and T1 research from behavioral sciences outside of oncology, mostly. They pull that in, they make a new intervention, or they borrow from old interventions very commonly, and they make a protocol that they really hope works. And they test it, they get funding, and then if it works, they do more of the same. And those interventions, again, get locked up in the institution, and they reach patients through trial recruitment, but that's not very many people. And those are very special people that are recruited. Even in the most flexible trials, they're motivated. They want to please the investigator. They're often paid. They're often given like a smartphone to do the virtual components. If there are some, there's a lot of special things about those people. They also tend not to have crazy overlapping problems like personality disorder, substance use. They all get ruled out or they don't sign up for trials. So everyone knows that. And we can't have those in every trial. But I still submit that this is where the gap is. So I think we can address this T2 to T3-4 gap in part. There's a lot of ways to address it. But I want to talk to you about clinical education. So why clinicians? Clinicians impact a huge number of patients. And it's essentially a teach you to fish thing, right? So if you teach a clinician how to do a technique, they can use it for every patient down the line that they see afterward. And that's fantastic. You can impact hundreds of people by training one person, maybe thousands of people. Clinicians can bring training back and train their teams and students. And when I've done this in many funded projects, we always have a train the trainers component. We kind of give them a toolkit to go back to their team and say, hey, this is what I learned at the big 3-day training. And here's how I'd like to share it. It's these basic components, simple stuff, but it works. And the interventions must be distilled into the core components. Yeah, Lauren.
Just a quick question of clarification. Clinicians, are we talking about psychology clinicians, medical oncology clinicians, surgeons? Like what type of cancer clinician?
So I've done work with all those groups, maybe not surgeons, but I've done work with oncologists, APPs, nurses, and most commonly the people that I've trained have been social workers and psychologists.
So are we talking about all of them here?
Yeah, we're actually talking about all of them. And I'll go through some projects that I've done that cover these things. Most of what I've done is on the psychosocial providers, the clinicians, the people that have time to do a therapy session with a patient. So I think, if you look at a T2 research design, there's a lot of stuff in there that we know works that the investigator had to put in that a clinician already knows how to do. They know how to engage a patient's social support. They know how to motivate basic coping, right? They know relaxation training, let's say. And so we don't need to retrain them on that. What we need are these core different things. And in any good research treatment protocol, there's a few things that are novel and that are like the secret sauce. And we want to distill those out and make them what the training's about, because nobody has time or money to do more than that. So we must have the clinicians in these trainings practice the skill and not just learn the material. I think because we're in academia, we think that if you can recite what it is, then therefore you must know how to do it. And that's sort of like trying to ride a bike by understanding the physics behind riding a bike. It doesn't work. You have to practice riding a bike, right? And this is very true in the clinical setting where things are difficult, messy, people have chemo burning, people need help. They're not always motivated to do what would work. And so motivation is vital for success. We need to change thinking and behavior, but it's very, very hard to do that for all of us, right? Like the whole country knows it needs to exercise more, but how many of us are able to do that? Behavior change is hard. I have found, and I think it's really important to teach the why behind the intervention. Why do we need to do this? And I'll give you an example from my sleep work that hopefully isn't too boring, about why we need to do the things in a leading therapy for sleep. To give you an example of what I'm talking about with the why. Clinician confidence. So a clinician that's practiced this and seen it work in multiple patients is much better at selling it to future patients, right? You're actually a salesman as a clinician. You're saying, I have this behavioral idea. I need you to implement it because it will help the problem you're struggling with. But you've got to be able to sell it to them. So then things from MI like rolling with resistance, setting goals. I'm a big fan of tiny goals. BJ Fogg's behavioral model from Stanford. The analog is if you want to start flossing because you've been slacking off at that, floss 1 tooth a day. And because you're holding the floss, you end up flossing all of your teeth. But it's a behavioral pattern. right? It makes you do that, and it sounds so simple, people are like, oh, fine, I'll do one of those. You have the worst day ever, you do one, and you've met your goal, and you can still be happy with yourself, right? So there's all these little behavioral tricks that clinicians know to get people motivated. I don't think we always have to retrain them on all that. So as you know, insomnia, a lot of my work has been in insomnia because I see it as this like great intervention that we have, easily treatable, low-hanging fruit, very common in oncology. So 30 to 60% of cancer survivors meet criteria for insomnia. And many of this is not a brief thing. This is an ongoing struggle for years during treatment and after treatment. Up to 85% meet the definition of insomnia, which is pretty hardcore. In active treatment in some populations, this 85% is from a study by Heather Jim, it was at Moffitt, looking at hospitalized allo transplant patients, which is the population I work with a lot. Insomnia worsens everything. You know this if you've ever had insomnia, it's terrible. You can't function, your social skills go out the window. If you have depression, it's worse. If you have anxiety, or even if you didn't, you just get more anxious. Your brain does not work well. I'm not gonna elaborate all of this, but you could give a lecture on each of these things. There's so much data to support it, it's unbelievable. I will mention that many people know that pain keeps folks awake, but many people don't know that not sleeping makes folks have a lot of pain, even if they didn't have pain before. It's a great way to treat pain. One of the latest R25s I was part of, I was doing the sleep component, but the whole R25 was about treating pain. And so they wanted me to come and do a sleep lecture because it's so important that clinicians know how to treat sleep problems to make pain better, especially chronic pain. So then we know when you treat insomnia, everything gets better. And I named these components that we have a lot of research support for. Again, you could do a whole lecture on that. So how do we treat insomnia? Most of you in this room have probably heard of CBTI, cognitive behavioral therapy for insomnia. It is the first line recommended treatment. Now, this surprises patients and doctors frequently because insomnia is such a big public health problem even outside of oncology, but there's these massive marketing budgets for pills, right? We all know them, Ambien, Nesta, a lot of times people use Ativan, there's all kinds of things, right? And, there's some utility, there's some populations where we want to use these, but they actually have a lot of problems and they don't work nearly as well, like half as well as the behavioral therapy. This therapy is effective in oncology patients. Josie Savard up at Ontario has done a ton of work in this area, and she did a meta-analysis of 8 studies that showed a really nice Cohen's d of 0.77. That's a nice effect size. Anybody would be happy to have that as a behavioral researcher. A lot of these studies show even higher impacts, right? This is a meta-analysis, so even the low end, high being average, you still get this great response. And the responses are durable. You do this therapy, honestly, you do this therapy for a month with somebody, and sometimes they're better for years. And they could have had insomnia for years, and you can fix it in 1 month of therapy. It's amazing. Minimal side effects, more effective and more durable than medication. So have I convinced you this is a good idea? Yeah, it's a good idea. It's underutilized in the cancer population, as it is nationally in the normal insomnia world too. Again, Josie Savard and some folks from Pittsburgh, who's like a big sleep mecca in Pittsburgh, as many of you know, figured out that the barriers to that include accessibility and training. So a lack of trained providers and a lack of many people are trained, but they're not comfortable doing it. It actually requires you to push your patients quite a bit. And that's often uncomfortable for folks that are used to doing supportive therapy, which is a be nice to patients exercise. This is often a little bit of a tough love kind of a therapy. It's very hard to do. So let me explain what it is. These are the 5 components. Now I have a 2-hour lecture on this, and so I'm consolidating it down into about 5 minutes. So I'm gonna leave some things out, but the first 2 things are basically the same. It's stimulus control, which means you only sleep in bed, and you don't sleep anywhere else, and you don't do awake stuff in bed either. Does that make sense? Mm-hmm. And sleep restriction is if you go to a normal person you don't have cancer and you have insomnia, they do sleep restriction, which is actually restricting into your total sleep time. I find this is very unpopular with cancer patients that are getting chemo and have fatigue. It's also probably not great for them, so I don't do it. I do something called sleep compression, which I'll walk you through in the next slide to explain what that is. Then it's cognitive therapy and relaxation techniques and sleep hygiene. Sleep hygiene does not work by itself. Eric Zhao at Harvard figured this out. He did a really nice trial with sequential patients in an oncology clinic. and found that a scaled intervention of CBTI, starting with sleep hygiene, the first step was ineffective for everybody that had insomnia. So sleep hygiene is also what the internet thinks CBTI is, and what like people sort of imagine CBTI is. It's these rules around getting good sleep, making sure you're at the right temperature, what's the noise level, it's all this basic stuff, right? And if there's a big deal breaker there, yeah, we address it. But it doesn't work without the other components. These are actually ranked in order of efficacy. People have done enough work in CBTI to really look at what's the secret sauce. And I would argue that the secret sauce, the distilled sort of shot glass of things we want to teach clinicians, are these first two components. Cognitive, you can treat a lot of sleep problems without even going into cognitive therapy. It's amazing. It takes a lot of time. So anyone know who this guy is? I'll give you a hint. He's Russian and he won a Nobel Prize. He loved dogs. There we go. So Pavlov discovered classical conditioning, as you all well know. And I'm putting him here to implant in your mind that this is a problem of classical conditioning. I find that most clinicians, even people that treat sleep regularly, don't know that this is how it works. Remember when I mentioned the why? The why in why you would do these difficult things is very much around eliminating behavioral conditioning that maintains insomnia. So most of us have bad nights of sleep. In fact, it's pretty normal once a month to have a night or two where you sleep half as much as normal, or where you sleep almost none. That's normal. That's not insomnia. What happens in insomnia, so we call that a precipitating event. Something stressful happens, you start a steroid, if you're getting chemo, you start a steroid, you don't sleep well, you get admitted to the hospital, you have a fever, whatever it is, it's a precipitating event. And that precipitating event triggers, in people that have insomnia, a bunch of conditioned arousal. So unlike the rest of us that start sleeping well after they're sleep deprived for a few nights, people with insomnia develop a pattern that's very understandable. They develop this pattern because they're lying awake in bed trying to sleep. They're distressed. They're often awake because they're anxious or they're in pain or they're dealing with some new side effect. And when that happens, that alertness pairs with the bed behaviorally, classical conditioning. It's not conscious 2 + 2 = 4 learning. It's unconscious. It pairs with the bed, and it makes the bed a place not of sleep, but a place of vigilance for the brain. I always tell patients this is an evolutionary biology story. This is not my idea. It's been thought about before. Evolutionary biology is a little fuzzy when you try to prove it because no one was around 20,000 years ago. Look what was happening. But we think that humans evolved probably somewhere in Africa, right? On the coast, in the plains. And it doesn't make any sense at all to lie down and sleep wherever you just darn well feel like it, right? And so the brain, because you get eaten by lions, right? And other animals that are up at night. And so it makes a lot of sense that any place you've been vigilant during the day or at night, any place you've been in pain, any place you've been anxious, your brain goes, hey, let's never sleep here again. And those are our ancestors, and they survived, and we have those circuits. So this is often referenced to explain the high prevalence of society, of insomnia in society. Like 12% of the US population at every given point has insomnia. It's weird. It's a very high prevalence disorder. And we have all these safe houses and sleep number beds, and you would think it would be better, right? But it's not. And so I share this with patients and clinicians to motivate them, because the goal is to take out this conditioned arousal. That is really the only goal of CBTI. And when you delete it, patients just start sleeping better automatically, and you recondition them to take back their bed as a place of sleep. So how do we do that? This is one of many techniques, but this is the sleep compression I referenced. So now we know why you need to do it. The how of doing it is so I put this crazy example in because the green bar is time awake in bed. This person is in bed for 12 hours. That's not normal outside of oncology. It's a lot more normal in oncology. People have fatigue that they're trying to solve by oversleeping. People have illness that keeps them in bed. And this is very, very common. And so what we actually want to do is have them restrict their time in bed, which most people don't like. You tell a person that came to you for help with insomnia to spend less time in bed, and they're like, what? What do you mean? And I say, okay, look, we're just going to compress your sleep, but we're not going to cut into your 6 hours that you were getting. Many patients, let's say they get 4 hours. The problem with that is that you say, okay, we actually need you to have 4.5 hours of sleep per night. So you go to bed at midnight and you wake up at 4:30 a.m. And they look at you like you're crazy, right? So this is why we need them motivated to get rid of this behavioral conditioning. Now, they don't have to live like that forever. So what we do is, and I think this one technique is basically a summary of most of CBTI, and it works very, very well. I've been doing this with patients for years. What you do is you say, okay, you restrict it down, you compress it down, and then once it starts working, once your sleep again fills in that 4 hours, 5 hours, 6 hours, then we're going to expand it out by a half hour per week. And what happens is magically your sleep follows, goes back to 7 or 8 hours, and then you don't have them spend any more extra time in bed. They just do 7 to 8 hours and that's it. And this works remarkably well. A lot of patients come back after the week and they call me and say, it's not working at all, and I'm super tired. And I'm like, stick with it for another week. It took me a long time to have the confidence to say that to people, right? I really like my patients. I don't want to make them suffer. I was like, stay with it. It almost always works. I would say 3/4 of people come back and they're like, I'm sleeping better than I have in a long time. Thank you. Right? It really, really works, but you have to really push it. So we've done these trainings, and I say we have been part of a bunch of people I'm going to show you on the next slide for these trainings. So I've probably trained about 1,500 clinicians over my 10 years doing this. Some in 3-day intensive trainings that also included other things like for anxiety and depression. I've done that work too. Or 90-minute virtual trainings. We always use live role play and mock clinical situations. So they can't just learn it, they have to practice it. Sometimes they have to practice it with each other or on stage. I've had funding on 4 separate R25s, including my own, to train cancer clinicians. City of Hope's got a huge supportive oncology program. They have a $25 million budget for their supportive oncology program every year. It's amazing. And they have funded a lot of national training programs that are virtual. So I've done a lot of those with them. And then we have a likely project to work with CDC and CDPHE coming up, which you hear about soon, but I think we're going to get 25K of funding to do that. Aaron Bowerly and I are doing that together. And these have been some of my mentors. So Matt Lascazzo is very famous in the psycho-oncology world as a clinician and program builder and sort of runner of APOS and a fantastic mentor. And he pulled me into one of his early R25s. He saw me present somewhere and was like, would you like to help us? And then I was a chicken because Matt's really famous and I'm really anxious. And I was a chicken for 2 years and like avoided him. And then I remembered what he said and I was like, I really do want to do that around sleep. So I went back to him and he gave me a slot. And then we ended up working together and we just finished an R25 together that we wrote with Bill Red, who is a super famous guy earlier in psycho-oncology. Bill is a hardcore researcher and has had like $50 million of funding in his career. It's unbelievable. And he's at Mount Sinai. He's about ready to retire. I think he's 82. He's a true Manhattanite, wears a bow tie everywhere. And Bill and I are co-PIs on this study that I'll share with you at the end of this talk. Karen Clark is the Director of Supportive Care at City of Hope. And Karen has been part of training 7,000 clinicians in different aspects and that's a huge impact. She won a big award a few years ago that I helped write our nomination for. And Bill won that award last year. So these are really people that specialize in that education. For those of you who are interested in getting into this kind of thing, there is, thankfully, this NIH NCI funded mechanism to do this. Nobody's getting rich off this thing. It's not, I think education is always sort of this third thing we do in academia, which is weird because we're an academic institution. Everyone's like, we get research dollars and see patients, but education, like, yeah, we're gonna pay you a little for it, but not a lot. But this is cool, it's NCI funding. You have to be associate or above to be a PI. There are 3 flavors of R25. There's one for curriculum or methods development, one for courses for skills development, which is what I've written all of these in. And then there's one for research, and a lot of them go to this last category, right? It's like how to do flow cytometry better. It's like these things that are very, very research. So a very small amount of NIH funding goes to this education. I'm always amazed that it's a research grant and it's actually really education. It almost doesn't fit with their mission. Right? I think it's okay that NCI doesn't always do this, but I'm glad they do. So up to 5 years total funding with up to $30,000 or $300,000 per year in direct costs, you can get 1.5 million total. There's, an 8% indirect limit. So big universities don't love that. They don't get much money. but it does give you more to spend on the patients, which is good, and the clinicians. And then there's a salary limit of 150K per year. If you have questions about this mechanism, or you're interested in writing one, I would love to talk to you about this a little more, and I can connect you with people that really know what they're doing in this department. And then I want to go through 2 projects briefly before talking about my R25 at the end, that are other ways in other populations that we've used this same approach of taking research knowledge, putting it into clinical practice in a very brief form. So the first project I did here with a bunch of people, including Jeannie Youngworth, who's still in our palliative care world, is on demoralization. Demoralization is a common phenomenon in oncology and cellular therapy patients. It can present as severe and it can really disrupt cancer treatment. It looks like depression, but the difference is it's very distinct in that anhedonia is usually absent, so they still can get interested in things and are curious about things and enjoy things. And their responsivity of mood remains present. So you can go and screen somebody to see if they're depressed or demoralized. If they're demoralized, you can have an in-depth conversation with them, sometimes for 20 minutes, and you can pop them right out of demoralization. It's like really fun to do because it's like immediately effective, and you do it by referencing their coping, their past coping. Demoralization, I tell my cowboy patients, is like you fell off the coping horse and you forgot how to cope. And it happens to really resilient people. They just get disconnected from it. They're overwhelmed by their treatment situation. Too many things in a row have blown out their coping. So like grief, it's normal, but we can fix it. And so what we did was we trained nurses with a video. We made a video like before it was easy to make a video. We had like a movie camera. This is in 2013. We trained nurses to do this, 31 of them, and we made them badge cards. And then we integrated it, worked really well. So we integrated it into the nurse training up on my floor, which we think it's still integrated into that. So all the cohorts of new nurses go through this thing. And we got right from T2 to T3, 4 there. So the nurses now do this, and they screen patients for depression. If they're depressed, they send them to the psychosocial team because that's a hard problem to solve. But if they're demoralized, they can intervene and they can refer, right? They can do both. And sometimes nurses are exactly in the right place for that. The other project I've done is with medical doctors, and it's training them in something that's outside my training, but that I could catch up on. And many of you know that chronic myeloid leukemia is a really interesting cancer. It used to kill a lot of people. It doesn't anymore, thankfully. And it's a very simple leukemia. Most leukemias are horrifically complicated. There's like thousands of mutations driving this, and they're hard to figure out what's the big driver and the little driver, and it's really, really complicated. But CML is driven by one mutation, and it's a 922 translocation, so the bottom bits of 9 and 22 just change places. And they make, on, I think, chromosome 22, they make this weird little BCR-ABL, which you can see the big arrow to there. BCR-ABL are 2 parts of the chromosome that are not supposed to be near each other. And unfortunately, that's an oncogene. It codes and makes cancer. So those cells don't want to die, they want to persist. And in the 1970s, research figured this out. And they figured out it's the first time ever in biology that for a cancer, a targeted therapy was developed for specifically that mutation. It was a tyrosine kinase inhibitor called Gleevec. In 1990s, that was implemented. Now we have tons of TKIs. This class of medications is great. And if patients take them every day and clinicians monitor that level of BCR-ABL, which is done through a qPCR like blood test, super simple, every 3 months, like 95% of people live a totally normal life. They have to take the pill. There's a few side effects, pretty well tolerated. They do great. And some of them can even stop taking the pills. Like it's actually cured. For some of them, they need to be on them, sort of like our division head says, it's like cutting the grass. Like you just need to have that there to keep it down at a really low molecular level, and it causes no problems. So the problem is that people don't do these 2 things. Patients aren't adherent, and the physicians aren't adherent to the NCCN guidelines. This is particularly true in 2013. So the primary problems in CML are no longer medical, they are behavioral, right? We've solved the medical problem fairly well. Not that we don't need to get better at that, but we really have solved it quite well, and it's amazing. You take a pill and your cancer's gone. That's the dream. But the behavioral problems are there. So I put in a picture here of an airplane because I did a study. We did an educational intervention that we made like a trivia quiz thing for doctors and APPs and nurses. in 4 programs across Colorado. And this was funded by the NCCN and Pfizer. So a $75,000 grant. I was PI. I had to learn a lot about CML, which was really fun. Dan Pollier and others in my program helped me with that. And we addressed these gaps in practice, which for time I won't go through every single piece of. But I got to fly across the Colorado mountains, and I wrote into my grant that I would fly in the state plane, which is this little tiny twin-engine Cessna that's pressurized. So I got to fly all the way over to Grand Junction in the middle of winter, which was like really cool because I like airplanes. And the pilot let me fly up to like almost wheels down on the approach. And I was like, this is the coolest thing that I've done. So I was like a flying, like educational doctor solving public health problems, and I got to fly in airplanes. It made my life at the time. So these 3 barriers though that we addressed were getting physicians to monitor, helping them select the right medication, and helping them address when their patients, many doctors say, so you're taking your pills, right? And patients go, uh-huh. And then that conversation moves on, right? And we all know that patients don't take their pills. Doctors in careful research don't even take medications they're prescribed. Everybody misses doses. So if your patient's not telling you they occasionally miss the dose, you're not assessing for this correctly. So we did a whole training on how doctors can assess and address patient adherence. And not just doctors, APPs and nurses too. And this is before the big push for oral onc adherence, which if you go into the cancer center, there's all these cool graphics trying to get nurses to do this right. So we did that at 4 sites, and it worked. The physicians responded really well, even though I was a psychologist teaching them, and it was great. And it did make impacts in the patient community and in the actual practice of the teams as well. And pre-post surveys show they gained a lot of knowledge from this. So the last thing, this is my last slide I will tell you about, is a project I'm really excited about. We have a lot of ends to still put together. But this is an R25 I wrote with Bill Red, and really Susan Moore, who's on this campus. I don't know if any of you know Susan. She's fantastic to work with. She's over in the mHealth lab, does technology-based stuff all the time. She does a lot of work in innovation as well, and she's in School of Public Health. And so Susan and I really actually wrote this. Bill is near retirement, and Bill's very supportive as a mentor. And when Bill retires, Susan will become a co-I with me, an MPN. Matt Lascalzo was a fantastic advisor and still is. And anytime you use Matt's name, it opens all these doors. So when we need somebody to market for us, Matt has been involved in the idea generation as well. And it's very helpful. So we have a shortage of cancer clinicians in the US. And I think that we can use technology, which is finally caught up and is good enough and penetrates enough into even our rural patient populations to help extend the reach of the cancer clinician. I do not think we want to replace the cancer clinician with technology. By technology, I mean app-based things, right? How many of our patients use Calm, right? Or Headspace, or some kind of meditation program, or something for exercise to remind them to work out and tell them what to do. There's tons of these. So we want to use existing technology to extend the reach of the cancer clinician. I'm big on app-augmented therapy. I do not think we want to live in a world where it's just tech, right? Maybe it gets good and we can do that, that's fine. But I think we need a clinician to find the right tech for people. A lot of the things that tech companies have done are not evidence-based, right? Yeah, I know the sleep world, and I look at stuff that they're recommending, I'm like, that's not gonna work, right? People like it, bedtime stories, all this stuff, like it may help some people, but you need much more organized stuff, and you need stuff that's been RCT tested, and a clinician is the right person to select and sell that technology. So we can make use of these wearable devices, right? Like my Apple Watch, like things that monitor sleep, that track steps, that track exercise, that track mood. There's a lot there. We can use technology in rural cancer populations to help bridge that gap. A lot of these apps require very low bandwidth, much lower than a synchronous video conversation. So you can see them when they're down for treatment, send them home with the app, and they can get better, and then they can come check in with you as they need to. It's a really nice model. Matt Lascalzo is bringing his work on ecological momentary assessment. He and his colleagues built an app for this. Do you guys know what EMA is? EMA is pinging people randomly throughout their life. Instead of saying, here's a survey, please fill it out, it pings them for a very brief assessment of their mood right in that moment. And it's a perfect time point. And you're like, oh, I'm actually really anxious. What can I do about that? And you can pair it with interventional ideas that are very brief. And it pops up on their smartphone, right? It's like a random thing. You guys know that the slot machine effect is real. Random reinforcement works better than scheduled reinforcement. even when the reinforcement is good, people get bored of getting little rewards. But they're really excited when the little rewards are random. So EMA is really great. So our first training, we have 13 presenters from all over the tech field in psycho-oncology. Our first training for cancer clinicians is January 30th to February 1st near Pasadena, California. It will be warm there. If you are a clinician and you see patients in any context, you're welcome to join us. We still have a few slots available. And we got funding, especially for people that are underrepresented in medicine, to attend and have some of the costs. The training's free, sponsored by the NIH, but to have some of the costs are free. So that is my presentation. If you have questions or discussion, you're welcome to email me, and we have a few minutes if folks would like to ask now. It's totally fine.
Yeah, we got plenty of time. Thank you. Questions, comments?
In your area of expertise or in your thoughts, what do you think is the next clinician education gap that should be addressed or is urgent?
I actually still think it's
You think it's sleep?
I think fatigue and circadian rhythms is a related thing.
Mm-hmm.
So we have good interventions for fatigue, but nobody does them. And part of the reason of that is actually a patient reason.
Mm-hmm.
It's because fatigued patients don't do stuff, right? Like a great intervention for cancer-related fatigue is exercise.
Right, that's
It's really hard, right? It's something that makes you wonder in the trials, like, did you just run like a Monte Carlo machine and say, well, the people who can exercise clearly have less fatigue, and then over the course of the trial, you just select them out and you say, this is our fantastic effect size, right?
Mm-hmm.
So we need something better. And I think something better are circadian interventions. This is also something that I'm really interested in studying. So time-restricted eating works for cancer-related fatigue. Light therapy works for cancer-related fatigue. These are all the same underlying mechanism, which is circadian alignment. And I wrote a grant for Gabriel's Angels, which is a blood cancer-specific intervention. They didn't like it, and I think it was the wrong mechanism. But I have the whole grant ready to go. And I talked with Susan, who's a tech expert. Would love, if other people are interested in looking at this work, to look at bridging this, because there's 4 interventions that work that are all circadian. And then Joanna Arch up north at CU Boulder has done fantastic work in fatigue therapy. And I think you could have an R25 that has sleep and fatigue, and you could have, a whole thing on meds. You could have, if you're gonna do a 3-day training, you could have a whole thing on circadian alignment and the biology and how to sell this to patients, which I do every day at the clinic. You can have people that are experts at sleep apnea, screening for sleep apnea, like all these pieces. And I don't think it's been done. I think it's probably the most underrepresented public health problem in oncology still. I mean, I've trained 1,200 clinicians, but that's a drop in the bucket, right? Like, I'm hoping that we can reach a much broader audience. And I would love to find ways of really scaling this big so that you train a lot of clinicians and maybe directly patients. With our CDPHE work, I wrote a proposal where we're going to actually train patients in a group telehealth format. A lot of the stuff on sleep. And I think that that'll be a really good format. Yeah, that's a good question. There's lots of other things how you could do it for so many other things. Anxiety would be great. Pain would be great. There was an R25 on pain recently, and it was very well attended. They had they maxed out their slots every single one of the interventions.
So is the R25 your primary mechanism for training physicians? Because in some of the work that I've done, actually getting physicians to attend trainings can be the biggest challenge.
Yeah.
So what are the methods you have for, where do you find the best uptake of training among clinicians?
So physicians are really hard. Like, they don't have time.
Okay.
I've never done, except for the CML grant, I've never done a targeted intervention for physicians. We get 1 or 2 in a training of 75, and these are 25s, right?
Yeah.
And we get a lot of psychiatrists who don't do therapy anymore, right? They all meds, and so they're really excited about this, which is great. But oncologists, I think there's a huge opportunity, and I'm not an oncologist, so I never feel like I should kind of be really careful with that turf, and I better really know my stuff molecularly, or they're going to be like, dude, you know what I'm talking about. And it worked with the CML thing, but I would love to partner with a physician or even a physician group to look at funding in that area. I think it'd be really cool. It's a great point.
I can speak to that a little bit too, because as a postdoc, my PI and R3, and to do a clinician education around communication for sexual health, we made a 2-episode podcast that was each, an hour each. One was education, one was communication skills they can use, and recruited quickly at great outcomes. But then the next step, of course, is like, how do you scale it? So I think one potentially untapped resource is either pairing with, and I'm talking about oncologists now, like pairing with medical school fellowship trainings to have a module or something embedded within their curriculum, because it's not there.
Right.
Made by old white men still in a lot of those curriculum. And then also giving them CME credits is another way, like if you can formalize and accreditate, another word?
Yeah, so we do this for all the R25, so we
Yeah.
get CME
Yeah.
credits, including physicians in the
It's awesome.
But I love that idea of going into the training programs themselves, right? I think that's really awesome.
It's easier to get people at that level for sure.
Yeah. Well, then a pod.
It's fun to break, it's fun to change and do
Exactly.
things differently.
They're not burnt out.
Yeah.
They aren't scared
Exactly.
of LGBTQ folks.
That's right.
Another question?
Yeah.
Yeah, I have you mentioned that the primary care setting or primary setting. I'm wondering what do you mean by primary setting here? And what's your opinion about like the collaborative model? Like we don't need to educate the oncologists, medical oncologists, or like those surgeons. We integrate the mental, like the behavioral health team with the oncologist team.
Yes.
Then it like they just do their own job and they don't need to like know that specific thing.
Yes, you're saying we could reach out to the oncologist directly and market to them. I want to address your first question, which was the primary practices that we are looking at recruiting from are these smaller cancer centers, because there's so many of them, and that's where most people with cancer are treated. There's a lot of breast and prostate cancer that does not require super fancy research-driven doctor to do it. It's standard treatment, and a lot of the country works that way. And so, yeah, that's what I mean by primary. I'm not as interested in looking at primary care practices, as a general health intervention. Although my wife does that work and has been really successful at getting, like, for instance, an MI protocol for vaccine hesitancy into the hands of like a bunch of practices in Colorado that are primary care practices, a big public health intervention to get vaccine uptake up. And that works really well, And so I wonder if we could borrow some of those models that you use for primary care and use them for this kind of thing too.
Is there another question down here? I thought I saw something here.
Oh,
Well, I have a question. So, lots of times, and I love your comments on translation, right? And how we move this through the process. But, sometimes this is structural, what insurance will pay for, what they won't pay for and such. So how does that kind of fit into your vision there about how this can become, translated in more efficient ways?
I think that comes down to a whole different side of the equation, which is advocacy. And it's fundraising, and it's advocacy, and it's policy. And I think those are great things. I said this is the first time I've presented this coherent idea. So I didn't plan my career to be focused on this like it looks like. I accidentally ended up doing these things because I love this work. And then looked back and was like, oh, there's a line, cool, And so I think like going forward, I do plan to be organized in this way. And I know that there's a lot of room for advocacy with ACS in Congress. This next 4 years might be very different. But I think that's a really good step. I know Matt Lascalzo, I just attended a leadership thing he did yesterday on fundraising, right? And how to get benefactors to fund things, foundations to fund things, but also individuals that are wealthy to fund things that they care about. And there's certain things they won't fund, like end of life stuff. They don't see that as worth funding, but they will fund things like a couple's cancer program, right? And so it's learning how to target that, to use funding to bridge that gap so people can do better therapy and they have more resources. So, is that kind of the angle that you're thinking of? This sort of like, we need better reimbursement, we need better.
Well, that's what I was thinking. Yeah, certainly our own cancer center here, we are the beneficiaries of a lot of, donations. We get millions of dollars that come in every year. But, as I see, especially when you're talking about these rural cancer centers, the smaller, units and such, I just wonder if that's a sustainable model, right? I think it can help us with our research and maybe, even figure out some implementation steps and ways that we can do this. But yeah, I think it's a deeper problem in terms of, just what is reimbursed and what is just becomes standard of care.
Yeah.
Yeah.
Yeah, I mean, I think
Yeah.
the accreditation bodies, like with the
Yeah.
American College of Surgeons, really have helped move that needle a little bit.
Yeah.
And I do think a lot of clinicians in these programs have trouble even getting time to attend the training.
Well,
Like
yeah.
there's fundamental problems.
Yeah.
And how this is valued versus how like the treatment that the patient needs or they will die, is valued. And I think to some extent there is a value difference there that's okay with, right? Like if we need to cure your cancer, that's really important. But if you're miserable doing it, we also need to work on that. So yeah, it's a big problem. And I don't think just my educational things or any version of educational things is going to solve anywhere near the whole problem. It's massive.
Yeah, I think the CMS is pushing something like that, like about the reimbursement thing, because they have an oncology care model that like trying to enhance the psychosocial needs, like to meet the psychosocial needs, and then they pay additional money to each patient during the episode because they only targeted to the people who are ongoing the chemotherapy. So they're targeted very specific, like maybe community cancer center, like the recommended cancer center, something like that. And they pay $160 per beneficiary per month during this 6-month episode of getting the chemotherapy to have the standard of care, to make the correlation, to have additional staff to support their social needs, something like that. And then they also have a specific quality of care metrics for pain management and the depression management. And they also targeted like specific for like the depression diagnosis and depression treatment.
That's great.
Yeah.
I know.
But they didn't have an improvement, like a significant improvement on like from their
In
data.
outcomes.
Yeah, on outcomes.
So more money did not equal better outcomes.
Yeah,
That's
maybe.
interesting.
But they don't look at like the actual data. They don't look at the claims data about like whether they received treatment, whether they had a diagnosis. They only look at the survey data, whether the patient feel better, like do they satisfied with the services the cancer center provided. Yeah. So I'm just like, okay, interesting.
Yeah.
So is that education? Like if we made the clinicians better at doing what they're doing, or is it just a hard needle to move?
Yeah. Interesting.
I'm thinking like there could be a gap of teaching around referrals, who to refer when, instead of having clinicians have to do new skills and change their own practice. I don't know, it's just something I'm thinking about, because again, I'm mainly about the oncologists. They got so much on their plate, they got 15 minutes to see their patient.
Yeah.
How are we gonna teach them to do CBTI?
Yeah.
I think you could do it pretty quick, to be honest. I'm on your side on that. But yeah, it seems so inefficient.
Yeah.
It does in general.
Yeah, and I think there's certain populations like an ABP might be a better target, or a nurse, like really selecting who the training's targeted.
Yeah. I think that makes it more sustainable.
Yeah.
For the sustainability. Any other questions? Well, thank you, Ben. That was really interesting.